And we're not going to get to all of the information here, but I want to cover one thing here. When we talk about underlying values that can trip us up in practice, one example is using visitation, child visitation, as a sanction for somebody who has relapsed or is still using drugs. And obviously that's something that the research and best practice standards do not recommend. You would not hopefully hold the kids hostage or penalize them or interrupt a bonding process or an opportunity to strengthen some parental interaction because someone has relapsed or may not have terminated or stopped their drug use. It may mean that there may be some things that you would want to do differently, like making sure the visit is safe, having other family members there, or having a supervised visit. And that's not to say if the person were, obviously intoxicated and out of control that you would carry through a visit. But we do hear, not so much in this state, but we do hear examples where the visitation is used as a sanction, which is not best practice. Yeah.
The logic that is given to me is that they want to see this parent show a commitment to getting their child back. So if they're not going to treatment, if they're not going to their therapy lesson, therapy sessions, et cetera, if you're not doing job search, then they're obviously not showing a commitment. So they need to do that in order to show that they want,
So yeah. So the logic that was presented here was that sometimes she was told that that it's a test for the mom to show that she's committed to the children by seeing if she can be abstinent in order to see the children. And that's one of those examples that in the abstract, in a perfect world, and a sentence pulled out of a document could you'd say, well, that kind of makes sense, but really everything has to be put back in the context, the reality context of addiction, and what does that mean, and how does that disease manifest itself, and what's happening in her brain. Just as if it's in so many ways a disability, as would be someone with bipolar disorder, that that argument that was just provided assumes a level of functionality, a level of brain activity, and a level of personal stability that may not exist at that point in time. And so, and the bottom line is, you ask, and you've seen the kids. In most examples, these kids desperately want to see their parents. Even parents that have been terribly abusive, there's something there where those kids really want and need to have access to their parents. You don't want to jeopardize their safety, obviously. You don't want them to see their parents if they're wildly drunk or out of control. But sometimes that's actually a protective factor, being able to see those children and remembering and being motivated. It's such a motivating factor to be able to see those kids and to know, wow, if I get my act together, if I can stick with this program, if I can have the amount of support I need, I can have that soon. And so that's that little shred of hope. And every time you yank it away, your chances continue to go downward in terms of your likelihood that person will seek a have a stable recovery. So we also have some values issues around data. Thankfully, not so much in Nebraska. Terrible issues in New Jersey and many other states where systems don't want to share data. But we have some data we're going to share with you in a few minutes. And so there seems to be good data sharing for the most part here. So we're going to go through some of these slides. Just that there's these clocks. There's a clock ticking on TANF, on temporary assistance to needy families. Used to be back in the day you could get whatever social economic assistance you needed. Now, and with good reason, but now there's clocks around how much time you have to spend trying to get a job and how many months you can have of support without having successful employment. The ASFA clock, which says that for 15 of the 22 months in out-of-home care, that you have to have a petition for termination of parental rights. And so in the time clock of some of these moms, if addiction is identified late, so let's say that mom, you've got an investigation, the children are taken, mom is there and the kids have gone, and now that is, let's say addiction is identified early, So the clock started the minute the kids walked out the door, but if she gets identified early, that addiction is a factor. Okay, so we know if they took the kids that child maltreatment occurred, but we don't always know addiction was a factor, so we want to know that early. Well, so how likely is that to happen in Nebraska? So we know that, and if I think I'm right when I say that, well, let me back up. Does anyone know the percentage of cases that are substance involved, in which substance is a factor in child maltreatment in general? So in the United States, the percentage of cases in which substance use is a factor. Anybody do they know or hazard a guess how many? 90%. That is probably true. But the demonstrated statistics by when all the big, large-scale federal studies is 40 to 60% of all cases. We think it's closer to 75, 80%, maybe more, is a factor. Does that mean it's the most important factor or the only factor? No, but it means it is a factor that will trip up your case if it's not dealt with. When you move to pulling the kids, when you remove to out-of-home care, that percentage nationally goes to 70%. So, and we have a little hint of what yours is, which is kind of good with the data I'll show you in a few minutes. So the good news is that if you identify this early, then and that clock is ticking, that mom has a good shot. Problem is, how many hours of training do you think child welfare workers get to deal with the problem that's in 50 to 60, or if pulled out of home care, 70% of their cases? Anybody want to guess how many hours or no? Two. Is that reasonable? I don't think so. I don't think it's on the planet of reasonable. 2 hours. Really? For a problem that's in 70% of your out-of-home cases? I would hate to be a child welfare worker in a state where I only got 2 hours, if I got that kind of support, 2 hours of training. And it really kind of, and this gets in my craw just a little, and since I'm so shy, I'm going to just try to get out there with this. We've offered free training. You can get, for a child welfare worker, 30 hours of free, really good training and CEUs. It's free. We give you, you can literally put it right into your Child Welfare Training Academy. That the state has not taken us up on our offer yet for that. The good news is you can go on your own and get it by going to our website, and I gave you the acronym NCSACW. I'm going to show you what it looks like. So it's not, we have all kinds of publications, policy tools, sample templates, sample memorandums of understanding, information sharing guidelines, drug testing protocols, these are all federally approved. These are not things you have to wonder, is it okay to put that in our state? All approved by the federal agencies that are responsible for these areas, that have the expertise. This is we have 4 hours of online tutorials, competency-based. So you know how when you go to a training, you could sit in the back of the room and on your BlackBerry, I know nobody does that, or that you could make your grocery list out or do something and really not always get the material. But these are competency-based, these 4 hours. You have to actually answer questions right in order to proceed in the training curricula, and actually for your certificate to get printed out. It's a very bold concept. So those are free. We have 3 of them. We have training that you can get if you're in the courts and you want to understand addiction treatment better. There's training for child welfare workers that explain addiction treatment. And there's training for addiction folks to help them understand ASFA and all of that. So you don't take all 3. You take whichever one, the system that you're in, you take that one. No cost, and it spits out your CEUs. Now, I do understand Nebraska is one of the few states that will not give you the CLEs for it, but I think someone's working on trying to get that resolved. This is the 30-hour, no charge. See, I told you that I will never recommend things that you can't accomplish. Okay, it has to be things that are no cost, low cost, free, or can be used with existing resources. This is free. We give you all the modules, the PowerPoint presentations, the handouts, the case studies, everything you need to do this. If you can read, you can pretty much get through this, and it's very good. So, and we're adding a medication-assisted treatment component in July. It'll be a webinar, but it's bringing in the leading experts in the country on medication, mostly methadone, but also other medications. And so that will be another add-on, because we felt like that we shorted that a little bit on this toolkit, but this is great. So, and don't look if I'm gonna spin backwards. If you get seasick like me or motion sick, I'm gonna make you dizzy here. Oh, no, I'm not, because no, there we go. So anyway, so we got this problem of high prevalence of substance use, low training. And so the other thing that happens is, in terms of that ASFA clock, that's where I'm trying to go here, that what you end up with is you're lucky if addiction gets identified at the point that your kids are taken. Because when I walk you through the data in a few minutes, you're going to see that we don't necessarily always identify it right away. Sometimes precious weeks and months tick by before addiction is picked up. And often it's, the messy house syndrome. We keep cleaning the mom's house, teaching her how to do it. We come back, it's messy, or other things happen and we say, something didn't get fixed here. Something's not being addressed. We're missing something. It's almost always addiction. Or there's other, examples where we see that the case is not proceeding and it's usually undiagnosed addiction. And then by the time they get it diagnosed, there's often delays in getting all these hoops that they go through, or they're not provided the kind of support they need to succeed in, let's say, outpatient treatment. They're not given transportation. They're not given other kinds of support. The other thing, and I hate that this happens, and I know it's a little bit here, I don't know how much here, and this happens in states that don't have the separate addiction and mental health systems that merge, and there's a lot of benefits to merging. I'm not going to say there isn't. But one thing that's lost is sometimes you lose substance abuse expertise. And you have people that are mental health professionals that may have had a handful of addiction cases, or you may have had a handful of trainings on addiction, but you may not have that background. And it plays out in a lot of sad ways. One is that the critical, absolutely fundamental, necessary component of AA and NA, which, and this gentleman in the back gave me a great example I'm going to use from now on, is like food to an addict. That's how necessary AA and NA is. Boost your success rate by about 50%. And I do the audits all over the country. I go into states where they've done the behavioral health mergers to look at the fallout that happens over time. It doesn't happen in the beginning, but you see it erode. The expertise in substance abuse erodes over time. If the state is not taking super proactive measures to make sure that that doesn't happen. And so you'll look at a client file and you'll see like the client's like hardly ever showing up. They're not getting the dosage that they needed. And so, and then I have to interview the clients, I interview the staff, and almost always the counselor will say this to me. I say, well, why is this client not showing up? First of all, how did they get an outpatient when they've had like 4 DUIs? And I'm just using my common sense here. Well, that was the level of care that came out by our counselor, okay, maybe they didn't have all the information they needed to make that judgment. And that happens here in a way I'll tell you about in a minute. But so they're in there, well, then they're not showing up. Well, why are they not showing up? You go meet with the client, and the client almost always will say something like this, and it's sometimes said, I'm going to say it nicer, but used to be, because I've been to treatment before, that it was different. Now I come, and we used to talk about real issues that were really dealing with us, that we dealt with, like how we needed to help get a better job, or how we needed to handle conflict with our families, or how we could do better parenting. Now we come in and we watch a lot of videos, and there's a lot of clients that are like zoned out on meds, and I can't relate to them, and I don't even know why I'm there, and I get nothing out of it, so I don't go. Then you interview the counselor, and the counselor says, how do you have a 200-person caseload? I ask them, like, come on, 200 people? Oh, well, because I have a large addiction caseload. They never show up anyway. And it's like, does no one get it? It's so frustrating. So you think, they really got short shrifted. Again, the substance use client, they almost always do. In these kinds of systems that have not protected the substance use expertise, that don't understand how AA and NA is. Oh, and the counselor will say, I said, how come there's no examples in here, no discussion around AA or NA? Oh, well, yeah, we have that phone. We give them that phone number. It's here somewhere. We got a list. We have a list. It's in the drawer, Oh, really? Okay. So instead of that, it's just like an afterthought rather than a fundamental component of treatment. Who do you think is going to be there when treatment goes away? And if you're one of these programs that does I call it treatment in a box, where you go to like the canned program of everybody gets the same thing. I call that program-centered treatment, not client-centered treatment. And I know that sometimes there's some good things that are offered in there, and there may be some evidence-based programs, and that's all cool. But it doesn't address the individual issues that each family has. So there really has to be other things that are provided and not just the same, treatment in a box, everybody gets the same thing. Their problems are not all the same, so why would we expect that their treatment would all be the same? So it's just not realistic. And so really looking at is addiction being identified at the earliest possible time, and are those people that are in those jobs trained and know what to look for? Then if it's identified, are they giving immediate opportunities to access whatever hoops you make them go through in the way of assessment, and then immediate treatment if at all possible? And if not, what are you giving them? If you have a 6-week list, that may be a reality. You may not be able to get them in. I mean, I'm troubled by that. But what are you doing for that client while they're waiting? What's the interim service package look like? And I hear there's sometimes nothing. So, how likely is that client going to come back in 6 weeks? So, meanwhile, that ASFA clock's spinning. It doesn't stop because of your bureaucracy. It doesn't stop because you missed the important identification opportunity. It doesn't stop because you failed to provide training for your staff to know how to make proper level of care diagnosis, or that you have, those child welfare workers have the benefit of some training so they know what to look for. So anyway, that's a real sad situation that happens there with TPRs that sometimes should not have happened. And not to say that there aren't ones that should, because we all know that is the case. So we call that the 5th clock, the clock that is ticking on us. We own a piece of this responsibility. This is the work we have chosen to do in our field. And if we take that on, we should take on the responsibilities that go with that. And that is to provide the best care we possibly can. And I also see this a lot. I know that some of these clients are hard to deal with. They're frustrating to deal with. Sometimes our value systems are like, really, how could you do that with these precious children? How could this happen? And we sometimes fail to step out of ourselves and our own biases and our own issues, which we all have, and say, what was that client's life like? What is their daily reality like? How did they didn't wake up one day and say, I know what I'm going to do. I'm going to beat the hell out of my kid and I'm going to use as many drugs. No, these were evolving cases over lots and lots of time and lots of missed opportunities to help them along the way, and people that were too busy maybe to even understand. And so what they really need, and it's real hard to give this sometimes, is a very compassionate, caring, nurturing kind of system and person that holds them accountable at the same time. So it's that dance between accountability and compassion. And instead, we end up with lots of folks who just get so upset that they really should not even be in this field. Or they need a timeout or a vacation or and we all have days like this. I'm not talking about all of us that have a bad day. I'm talking about the way our system performs and the way we perform in general. And so we end up really getting back the very kind of response so that the clients perform for us as we expect them to. And it doesn't cost any money to be caring and compassionate. And when that person shows up, and they may have had to take 3 buses to get there, or they may have had to give someone sex to get to your front door. You may be clueless about that, but that's often how they get there. They don't have their own transportation. How do you think they get there if you don't have transportation? So they may have done very degrading things just to show up, and you don't know that, or they're late. Nope, you missed it. You're too late. We're not going to open the door, or they don't come. And so to be able to say to them, I'm so glad to see you. I know it was probably not easy for you to get here. Come, have a seat. Put your feet up. Sit down. Relax. We're gonna spend the time today really working through whatever what's on your mind. What barriers can I help remove for you? What can we do? What services do you need? I notice you haven't had any work history. What can we do? If you don't provide, you can do the treatment in a box and you can do all that, whatever that is. But if you don't do these other things, then you're very unlikely to really make a difference. And for that person to feel like you might have been the one person that really cared enough about them to, or if they didn't show up, I was worried about you. I noticed last week you told me that you had so-and-so with a fight with a boyfriend, and I really couldn't help but wonder if that maybe tripped you up somehow. So now they know you were thinking about them when they weren't there. You weren't just checking off a box, and you weren't. So, that's a whole other conversation. But it doesn't cost any money to do these things. It costs nothing. So so the clock's ticking, and we may be missing these opportunities. We may not even offer engagement, recovery support, which is really a critical piece of addiction. Sometimes they have that in mental health, but we don't get that same benefit in addiction. Maybe meds in mental health, we don't get that same benefit in addiction. And that may not be the case here in Nebraska. Let me put that disclaimer out. We talked about time to treatment, what's reasonable. So this is an example of what good family-based treatment looks like, because we are dealing with families, and that's another values difference sometimes in our systems. The addiction treatment system tends to look at the parent or parents, and the child welfare system tends to look at the kids. And it's like, who's looking at the family? Because these things, if you deal with them separately, you miss real opportunities to make improvements. And so this is a example of, and don't think of this as residential. It's very easy to think that, oh, you must mean residential, and we don't mean residential. It's obviously easier to incorporate in residential. But a level 1 program would be a treatment program that services are there for the women with substance use disorders. There's a treatment plan. It may include family issues, and I'm here to tell you they all don't, and I've seen some. So even though she's in child welfare, I guarantee you there are treatment plans that in the treatment center, maybe not in child welfare, but in the treatment center, that don't even really discuss that family, even though that's, why she's there. So, but let's at least give them the credit. So there's probably a level 0, okay, let's be real, but let's give them the benefit of the doubt, level 1, that every family, every treatment plan that if it's a woman that's in, or a family, a parent that's in substance use disorder treatment that has child welfare involvement has families on their substance abuse treatment plan. And the goals typically, though, on a level 1 program are improved outcomes for women. So level 2, the children accompany the women to treatment, and that's why people think I mean residential. And this is women, kids can come to treatment in a lot of different formats, and it doesn't have to be residential. And it doesn't mean that they have to come every session, but that it means that that addiction worker recognizes that there are other parts to this family that this addiction is affecting, that need to be included, that that you want to get your eyes on those kids, and that you want to see how they fit and what kind of services they might need, and are their needs being taken care of, and how is mom interacting with those kids, and so forth. And so how you plan that out is really dependent on a lot of other issues, but at least in level 2 they do come at some point. But still only the women have treatment plans, and the goal is still only around the women. So we're still missing in level 2 the children. Level 3, the children come with women to treatment. Women are attending, and children have treatment plans. And receive appropriate services. And so the goal is improved outcomes for women and children and better parenting. And then level 4, children accompany the women to treatment. Women and children both have treatment plans. Some services are provided to other family members. The untreated partner is the #1 cause of relapse. So what are you doing with the partners when you're doing all this work? And that's a married partner, unmarried partner, lesbian partner, whoever the partner is. And so, so a level 4 program is like, yeah, we get that. We're not going to spend all this time over here trying to fix mom, independent of all the context that she has to deal with. So we try to look at this more globally. And then the goal here is improved outcomes for women and children and better parenting. And then last, the highest level, level 5 program, has a treatment plan for every family member and receives individual and family services. And the goals are improved outcomes for women, children, and other family members, and better parenting and family functioning. This is also potentially a tool in looking at reasonableness of efforts. Where was the program? What should have been provided? What was provided? And these things don't have to cost money more than what resources are already in the system. And I'm gonna show you a video now. We've already gone through this. Let me just make sure there's nothing else before I shut this one down. By the way, as you probably know, with health reform, that residential treatment is going to be harder and harder to fund. The insurance plans are not going to fund that. I've spent some time in Massachusetts looking at their plans, and they're looking at like 11 days of residential treatment, 14 days. There's lots of limits to what's happening as care is managed. And so what happens is that level of care that we already know is so needed, that's hardly available now, is even going to be available less in the future. And so it really is incumbent on us as system participants and leaders and so forth to look at what we can do. Am I doing something wrong? I'm sorry. Oh, okay. I thought am I moving around or giving you background? Okay. Yes, thank you. I saw that there was some little noise over there, and I thought I was messing something up. Sorry. So anyway, so we want to be able to get ahead of that problem that we know is coming down the pike in 2014. So we really, this whole issue of level of care and what type of treatment is really critical. One thing I do want to say, and I'm not saying this is a problem in this state, though it isn't a problem in many states in which they have managed care, that sometimes the cost of managing certain levels of care costs more than if you actually provided the care outright, and that is often the case in some of the some of the regular level 1 outpatient, low level outpatient. Sometimes the bureaucracy behind getting the approval, and the delay in weeks of time, and all the efforts that we all spend chasing mom around trying to drag her in weeks later, and then all the paperwork that has to go with getting her in and with utilization review and costs more than if you just let her go to outpatient treatment from the beginning. That is not the case as you get higher up. But that's what frustrates me so much after 31 years of doing this, to say we have money in our systems, we're just not always using it in the right way. So those are, I realize, things y'all can't fix. Hopefully some of our system leaders will start looking at if the argument for managing care is saving money, show us that you saved it, okay? And you probably did at some levels. It's probably not so much at that outpatient level. And so that money could have been used maybe in other ways that are more helpful. And then the other issue is around the managing entities sometimes save the money, but if you're not getting the right treatment, the right time, and the right dosage, that client's going to come back. And the costs to the system are going to be in the child welfare system, in the homeless shelters, in the jails and prisons, and in other places. And we have data that will show what are the impacts of the things that we do if we're brave enough to gather it and look at it, and then most importantly, do something about it. So what I want to do now, before we go into the data, is I want to show a video, and I want to just set the stage real quickly for this. I told you I was appointed by 2 different governors in Florida to head up the drug treatment system, and my phone would ring frequently, oh, I've got this great program, we'd like you to come see it, because I would have to brief the governor on what was happening in drug treatment in Florida. And so one day, in a really tired day, somebody says, yeah, I got this great program, but they mentioned 2 magical words of, it's in Key West. And I do admit I made some adjustments to my calendar, and took one for the team, got on a plane, went down to Key West, and was truly, actually I even had plans in the afternoon. I'm like, oh, this won't take long. This was a public housing authority. They don't know anything about drug treatment. They know about the problem. They know about the cost to the apartments and all property management from having drug clients renting. They know nothing about treatment. I'll breeze through here in no time. And I forgot that the head of HUD was supposed to join me, and then he was incarcerated or embezzling something, and I got the second in command. So she and I went, and so what unbeknownst to me, this housing authority that had asked me to come down was videoing me, and I didn't even know they were doing this. Little did I know when they were videotaping me that they were eventually, years later, going to make a movie that is the one I'm fixing to show you, and that I was going to be in it, or that I would even be running this very program that I was so impressed with. So that's a little context. So you'll see a much younger, thinner version. But then also, when I ran the program, I ended up having a baby the next day. So you'll go like, really, that's her? She changes a lot. I just want you to know it's a lot younger and thinner, and then about ready to deliver. And so that is still me. And this was a video that is about 17 minutes long. It's very sad at the end. So if you need Kleenex or anything, you might. Yesterday I showed it, and there were all these people sobbing. I felt bad because I didn't tell them to get Kleenex. But anyway, or have something to drink. That's what I always do. But anyway, water I meant. I didn't mean alcohol, obviously. That works, but we're not going to recommend that here. So we're going to show that, then we're going to talk a little bit about that. And I do want to tell you that this program is not open any longer for 2 or 3 reasons, although it's spawned numerous programs around this country. And but I'll tell you why it's not open later. It's all good. So let's see. Can someone hit the lights?